what they were trying to argue is actually it doesn't matter if you have many eggs. What I want to argue is actually you don't need many eggs, because if you can get the same response with 4 to 10 eggs, then why bother with over 20 eggs if you're not going to increase your success rate? So I'll use the data in the kind of opposite way than what it was actually originally presented. Now, okay, we've spoken about conventional retrospective data looking at what's the optimal number, and the studies have showed 13, 15, but somewhere around those kind of numbers. Well, how about, oops, that was not me, here we go. How about, other protocols, so my IVF. So this is interesting prospective data that showed that actually 5 should be enough. And again, they compared groups between mild stimulation and conventional stimulation, and they found that the median number of eggs in this group was 9, and the mild stimulation was 5. So according to dogma, this group should do a lot worse than this group because more eggs is better, and that's what people keep on talking about. Now, interestingly, when you look at the ongoing pregnancy rate per embryo transferred and the implantation rate, according to the numbers with the two groups, so this is the mild stimulation number of eggs and this is the conventional stimulation, you actually find that although there is a small statistical significance increased rate for the implantation of the mild IVF, let's just assume that is the same. I'm not going to make a claim that it is better. It's a very kind of borderline statistical significance, but the point is, with the fewer eggs, you can have the same, if not better, success rate. So again, why could this be? Obviously, more is always better, clearly. Well, there is some evidence emerging why that could be the case, and there's a series of little data that's been coming out. So this is a study that looked at an association between high yield of oocytes and increased rate of chromosomally abnormal eggs. And actually, as you can see, and there are some problems. They used polar body testing, and obviously looking at just a small number of chromosomes with fish. But I think it kind of makes the point, sorry, I keep on going back, that the more eggs you create, the higher the chromosomal error rate. So actually, that could probably explain why you don't need more eggs. But another interesting story is, well, why are eggs so abnormal? And this is, again, looking at conventional downregulation protocols, so long protocols for the conventional type of IVF. And they looked at a number of eggs and embryo transfer, and it was a very interesting mathematical modeling of how they came up with this number, but I think the gist of it is quite well illustrated at the end, that approximately only about 5% of fresh eggs can produce a baby in women who are what are considered to be a good prognosis group, which is less than 35 years old. And obviously, as one would expect, the older the lady, the less likely you are to have a normal egg, and for over the age of 40, they actually find only 1% of eggs can actually produce a baby. Now, interestingly, we found very similar results. I can't compare obviously the two groups because they're not comparable, but this is from our group that was presented at Escher a couple of years ago, and it looked at the birth to oocyte ratio. That's how it's kind of been dubbed as a number. And you can see that although we purposely did not try to retrieve a large number of oocytes, actually the higher your antral follicle count, the less likely per egg you are to get a baby. So I think it's quite interesting to talk about what is actually required from a normality point of view and how many eggs you need. Now, obviously, an abnormal egg is going to lead to an abnormal embryo. And there, again, has been some data to look, well, how many of these embryos that we look at actually are normal? And the answer is quite a lot of them are not. And it seems that also the more you create, the more abnormal embryos you create. So this is an interesting paper that looked again at eggs and cycles from conventional IVF versus mild IVF. And obviously, what it showed, as we'd expected, there is a significant higher number of oocytes retrieved and a significant higher number of embryos created. So one would expect more is better. Actually, though, when you look at the number of embryos within those groups that were chromosomally normal, they were exactly the same despite there were fewer embryos. So effectively, just to illustrate graphically, you have more embryos created that look nice from conventional stimulation and fewer from mild stimulation, so clearly more is better. However, when you test them, it's the same numbers. So I think this is quite good proof now to show that it also makes sense from a biological point of view that you don't need more eggs to have the same number of good quality embryos. So I think the first myth that more is better, there is some evidence to show that that is not the case. Now, I've put together the next two myths just for, because I think a lot of the evidence kind of overlaps. And this is a myth that I have been subject to many times when I go to conferences around the UK, and people say, oh, where do you work, what do you do? And they go, oh, natural cycle IVF and mass stimulation. That's only a marketing ploy, and it really, it doesn't give better success rate, you know that. And obviously, when I was training, I was told that OHSS does not negatively affect the pregnancy outcome, so it doesn't matter. And, it doesn't really matter as long as you can manage it properly. So yes, okay, maybe it's uncomfortable for the women, but actually it means it's better, because if you do get ovarian hyperstimulation, it means you're pregnant, so fantastic. And that's how I was actually trained. Now, I think it's important to actually discuss what is the true success of IVF, because a lot of the papers, a lot of clinics just define it, well, as a positive pregnancy test, as an ongoing pregnancy test, as a baby, as a normal baby. And I think really you should see it its entirety. And really, as far as I think all of us in the room are concerned, is that it's a healthy pregnancy and a healthy mother with a full-term, normal weighing, healthy singleton baby, with no harm to either the woman, really at an affordable cost, but you can put that in brackets, and also no long-term health concerns. And we have responsibility as doctors to actually ensure the health of our patients. Primo non nocere, first do no harm. It is what we're all here for. So why is this important? Well, there has been a lot of kind of concern that actually just the process of assisted reproduction can actually cause problems with pregnancies. And looking again at, this is again all conventional stimulated pregnancies, and for every single obstetric outcome is a significant detriment when you have, and these are all a single embryo transfer, so that we're not talking about twins or triplets or anything like that, which also will increase a lot more the complication rate. But there seems to be a genuine something there that causes worse pregnancy outcomes. So we have to take it seriously. Now, a lot of people argue maybe it's the fact that the population that we're treating are inherently going to be more, have a higher risk of obstetric complications. So, is it the chicken or the egg? Sorry for the pun. So again, there is some data that this came out from this year's ESHRE meeting. And this is data that looked, again, at conventional stimulated cycles. And what they wanted to see is what is the obstetric outcome compared to the amount of the ovarian response to stimulation. So without boring with too much detail, again, there were no twins and triplets, all about singletons, and they defined hyper-response as, again, more than those 15 eggs collected, again, because it comes from the same group that showed that 15 is the magic number, and they compared it to what they referred to as normal responsive women, which was 4 to 15 eggs. And I think, interestingly, all the women that had an increased response to ovarian stimulation seemed to have poor obstetric outcomes. And what is clinically relevant is really the ones which are the extreme low birth weight and extreme preterm birth, because according to Barker's hypothesis, that actually has long-term implications for the child. So, as I said, this is for conventionally stimulated cycles. Well, is there anything to show that mild stimulated cycles actually have any benefit over conventional in this kind of respect? So, this is a study that came out a few years ago, and it compared standard stimulation versus a modified natural cycles, and they didn't find a difference in either the prematurity rate or the pregnancy duration, as the other study found, but they did find a significant difference in the mean birth weight. Now, the question always going to be, why is this happening? Is it the environment that is causing the obstetric problems? So we all know that, by and large, higher response to stimulation will go hand in hand with higher estrogen levels, which does affect the endometrium. So is there a correlation? Is it that, or is it something genuinely wrong with the eggs? And more studies have been coming out now comparing fresh transfers to frozen transfers, and there is quite a bit of evidence accumulating now that when you have transfers in cycles which have been stimulated and have reasonable estrogen levels, so supraphysiological, more than what you would get in a normal cycle, it does lead to increased prematurity and increased problems with low and very low birth weight and stillbirths. And when you correct for that environment by putting frozen embryos inside the uterine cavity in a natural cycle, what you do find is that you have a higher birth rate. If anything, actually, there is a tendency to maybe have macrosomia, which has its own problems. So it's an interesting kind of a problem there. It would be very interesting to see if this still holds for natural and natural modified cycles, where actually the estrogen levels don't tend to be so supraphysiological, and they can still be within the range of what you would expect during a natural cycle. So there is, I guess, quite a bit of evidence now saying that maybe it's the environment as well, which is important. But the question is, does it really work, this mild stimulation? So we've seen some data before, because as I said, some of the criticisms that I've been given is that it just doesn't work very much, and you know that in just a marketing ploy. Well, interesting studies to look at the mild strategy, so actually very low stimulation versus the traditional kind of conventional way of IVF. And I have to explain that this is over a period of a year, so it's what was referred to as completing a course of treatment. I always try to explain to my patients that fertility treatment is not necessarily like, it's not a one-shot approach. It's not like you have a gallbladder problem, you remove it, have one operation, end of, that's it. It is a course of treatment that might need to be done more than once, and unfortunately, because of the way that funding around the world is or is not available, a lot of couples see it as it's a one-shot, and the same way that you wouldn't take one tablet of antibiotic to treat an infection, but you would take a course, you should see it the same way. So there are other issues there that come into consideration, like funding, but if you look at it as a complete treatment, then the mild strategy, so lower stimulation, will give you an equivalent term live birth rate as with the conventional stimulated approach, but a lot lower hyperstimulation, and obviously less medication. So, and that's why the mean cycle length is slightly higher in the mild strategy. But as we become better at actually knowing how to use these kind of new approaches and new protocols, I think the per cycle rate, as I showed in some of the previous data, actually is probably equivalent, if not a little bit better, if we believe that one study. And that really leads to the other myth that OHSS is an unpredictable and unavoidable complication. Now, I hope that no one believes it in this room, but there are some predictive patterns within a cycle that can give you kind of the inkling that you're going to have hyperstimulation. So obviously everybody knows about the number of oocytes as a predictor, and there's some good studies to show now that if the larger the number of eggs retrieved, the larger your probability of actually having ovarian hyperstimulation. And again, the live birth rate it plateaus after a point. So all you're doing is giving complications, but you're actually not giving any benefit. This is just the receiver operating curve of the prediction model for this, just by using a number of eggs collected. Now, of course, there are other predictors and markers of ovarian hyperstimulation. So AMH levels at baseline seems to be a good marker as well, and I think probably underused. I think we probably use it more as a predictor of how ovaries were going to respond, rather than in itself predicting hyperstimulation regardless of the response. Because if you compare it to FSH alone or alone to antral count, and I'm sorry, Professor Campbell, for this slide, but obviously they didn't look at stromal flow, which is a different thing altogether. So that's why function is more important than just structure. Both for PCOS, which is the darker, and for normal ovaries, clearly the higher your AMH, the more likely you are to have hyperstimulation. And again, just to illustrate the receiver operating curves, that the AMH seemed to be the best one of all those. And apart from AMH, there have been other markers like estradiol, which is interesting because we use it quite a lot as a cutoff point. But not all the studies show that estradiol on its own actually are the best predictors of ovarian hyperstimulation. So this is comparing estradiol to the number of follicles. So clearly the prediction of the number of follicles is better from the receiver operating curve than just estradiol alone in the day of recollection. If you combine the two, you can get a specificity and sensitivity around kind of the low 80%. Now, why is this important? Because we've heard a lot of talk about OHSS-free clinics, and why OHSS is important, because there are reported deaths in the literature. Now, of course, you might say it's not very high, but my argument is, why should you have it at all? And there have been a lot of debate that you can potentially eradicate ovarian hyperstimulation syndrome with agonist triggers, but you have to use, obviously, antagonist cycles by freezing the eggs or the embryos, and obviously with increased rate of vitrification, I think clinics are more likely to do it. Clearly, when I was starting the vitrification, well, it was slow freezing, it was so poor results that you may as well just take your chances with OHSS rather than effectively destroy your embryos with your poor freezing. Now, a little bit disappointingly, alarmingly, there have been a couple of reports now of well-managed cases and severe hyperstimulation with trigger, with GnRH trigger, despite the fact that they were given, in one case, carbapenem, which you can believe if it works or not, but there's some evidence that maybe it works, and they definitely had an agonist trigger and a freeze-all approach. So this paper reported some, and apparently I was just talking to Professor Garcia Velasco, and he told me that there are 2 more cases from Turkey that have come up as well. So maybe we can't have a completely OHSS-free clinic, but definitely we can have a near complete. And I think if you are very careful about your stimulation, you could probably make it virtually zero, but maybe never 100% zero. Nothing in life is zero, unfortunately. So this really leads to my next myth, which is that the traditional long agonist protocols are better than antagonist protocols, which is what a lot of people still believe, and definitely in this country. And this really kind of stemmed from the fact that there was an RCT that came up from the Cochrane group in 2006 that showed that you get lower pregnancy rates per cycle. However, a meta-analysis, apologies, from the same group with more randomized controlled trials showed that there's no difference in live birth rates, but there was a large reduction, as expected, in ovarian hyperstimulation syndrome and also reduced duration of treatment. Now, okay, so this is all about women with normal ovarian reserve. How about in women with low ovarian reserve? So this was a trial that came out last year that it compared for poor responders, which were defined as basically having been stimulated with 300 of units of gonal-F, so recombinant FSH, and have not reached 3 follicles which were larger than 17 millimeters. So that was considered as a poor response. And then they randomized them into either the conventional kind of long agonist with high doses now, 450 units of recombinant FSH, or what they referred to as the agonist short, which is basically the flare protocol, versus the antagonist group. So the flare protocol and the agonist group had 450 units, so very high doses. And just as what they showed, as one could expect, is that you get a higher number of eggs with the long agonist protocol compared to the flare, but actually not compared to the antagonist regimens. And the duration of stimulation was significantly longer with this approach. But I think what is very interesting is the last point, which the pregnancy rates seem to be a lot better, and it was statistically significant with the antagonist protocol. So I think this kind of proves now that antagonist cycles are not worse than the conventional IVF. The advantage of antagonist cycles is you can tailor them in order to avoid hyperstimulation, and you can use them with a mild approach. So clearly, that is the way forward. And I'll have to thank Professor Friedman and Professor Bashar, I think, for coming up with the antagonist and to allow for this to happen. This is my favorite myth, really. Right, natural killer cells kill pregnancies. And you say, oh, you know, this is a kind of a very dramatization. Well, I don't know in other countries, but in this country, we get a lot of headlines like this. So, you know, killer cells are robbed me of my babies, and, you know, and cause so many, untold misery. And I particularly like this one here, where natural killer cells, which fight and kill the embryos, can be treated with egg yolk treatment. I have to admit, it took me a few minutes to understand what actually they meant until I realized that they're talking about intralipids. So, okay, let's look at natural killer cells. And what is the relevance to their ability or not to kill pregnancies and babies, according to the headlines. And this is important is because every day in my clinical practice, I'll sit opposite couples that come with all sorts of expensive tests, and they will say, I have a high immunity, I have killer cells in my body, so I need X, Y, Z. And it's very difficult to try to convince them when you have a very convincing person who's told them that they have a killer cells, and obviously that's why they can't fall pregnant, why actually that might not be the case. So coming back to the natural killer cells, what, if any, is the association between these and the various groups of patients that we see? So this is, again, a meta-analysis from a group that actually deals mainly with uterine natural killer cells, which is a different population altogether, but they looked at everything. So, okay, so what's the chance of miscarrying if you have high peripheral NK cells versus normal? Well, it doesn't make a difference, actually. If you have high or low, your chance of miscarriage is the same. Okay, well, how about miscarriage after success from IVF treatment if you have high or low peripheral natural killer cells? Again, no significant difference. Okay, how about implantation failure altogether if you have high NK cells? Clearly that kind of makes sense because it will kill the embryos early on. Again, no difference if you have high or, well, whatever you define as high, but high or normal peripheral natural killer cells to what it's going to do. Okay, well, this is the important one. How about the uterine? Again, doesn't seem to have a major difference in your chance of having recurrent miscarriages. Now, obviously, a lot of these studies are very small, and you'll see that the numbers are very, very small. So maybe more, as every meta-analysis will say, more data is required. But that doesn't stop people from actually treating natural killer cells, because since they don't seem to have a big difference in the phenotype of the patients that you treat, you may as well just treat them anyways, because you can cure this problem. So, okay, why, what is being used? So everybody knows about IVIG and intralipids. So I'm going to start with IVIG, and it's been used for either recurrent implantation failures or for patients where you've tested them and they've been shown to have raised peripheral natural killer cells or toxicity, an abnormal T helper 1 to T helper 2 ratio, and all sorts of kind of other problems like HLA antigen similarity. And the proposed mechanism of action is that IVIG inhibits the cell production for the natural killer cells and their activity, and it corrects this abnormal T helper 1, T helper 2 ratio, and also has some non-specific immunomodulation, and it enhances immunological tolerance. So all sounds very plausible up to now. And I have to admit, unfortunately, when I actually looked at it, and there was a systematic review meta-analysis that was in 2013 that looked at almost 1,500 women from 10 studies, it seemed to actually prove the fact that although natural killer cells in the periphery don't seem to have any correlation in the patient group, it seems to be able to treat this problem with higher implantation rate, higher clinical pregnancy rate, higher live birth rates, and lower chance of miscarriage. But as anybody who looks at any paper in detail can tell you, is what you put in is important as to what's going to come out. So the problem with most of the studies that were included, they had some important methodological flaws. Most of them were poorly designed, they were retrospective, they were clinically heterogeneous, they didn't have any randomization, a lot of them, and most importantly, they compared the results with historical controls, and actually they didn't have any control to compare to. So I think we have to take with a pinch of salt that meta-analysis just because of the quality of the data that were included within it. But okay, we can argue that maybe there is some benefit. I think the real problem for me is what IVIG is, and most patients don't realize that actually it's a pooled blood product that carries potential risks, and some of them very significant. Now, about a third of patients that take IVIG will have some sort of complication. It might be a minor complication like itching or flushing, headaches, nausea, fatigue, a skin reaction. But there's a small minority of rare complications which are very, very important. I think if you told a lot of women what their actually IVIG is and where it comes from, they might be a little bit more reluctant to have it. And I think it's very important, I think in medicine, that if a treatment is uncertain in the way that it works and its efficacy, it should at least be safe. And giving untested treatment, which is not safe, I think that really, I think, crosses a certain kind of moral kind of line. Beyond that, I don't have time to talk about intralipids, but I can assure you that the evidence is even more lacking there. You can argue at least intralipids don't have as many side effects or costs as IVIG, but still you shouldn't use something that you don't need. Or more importantly, label somebody with something they might not have. So I think enough said about that myth. Now, this comes to my final one, which on the face of it actually is true. So blastocyst embryo transfer is better than cleavage stage transfer. So most people, if you ask them, will agree with this. And I have to talk to a lot of my patients and they say, well, surely with my one embryo that we've got from my very poor ovarian reserve, we should keep it up to blastocyst because that's a better success rate. And you know, as if something magic happens in the lab and you kind of help the embryo become better if you leave it to day 5 rather than day 2 or 3. So, I mean, there's no question that when you leave it to blastocyst, you can get a better idea of its quality based on morphology and also the fact that it just made it there in the first place. However, if you look again at the evidence from the Cochrane review that came out a couple of years ago, it showed that if you look at one transfer, there's a small significant increase in the live birth rate for blastocysts. However, if you look at the cumulative rate, and this is coming back to my point that you should always try to explain to couples that it's a course of treatment, it's not just a one-off shot. So if you look at the cumulative success rate, actually with cleavage stage, you have a higher clinical pregnancy rate if you include, as I said, the fresh and the thaws and the frozen cycles. And also that can be explained by the fact that if you go for a cleavage stage transfer, you have a larger number, or have a higher possibility of actually having embryos frozen, because some of those embryos will not make it to blastocysts, and not all of them are embryos which are abnormal, just not necessarily in the right place. But if we take away for a minute the actual success rate, and let's say, okay, maybe the patient wants to have the best chance in one go, so they don't have to pay for the second go, is there actually any other problem with actually putting blastocysts back? And there's emerging data to show that actually maybe there are some fundamental differences between blastocyst embryos and cleavage stage embryos. And if you look at the recent meta-analysis of comparing twinning rates in blastocysts, there is a significant increase in monozygotic twins following blastocyst transfer, which is almost it's more than 4 times relative risk higher than natural conception, but actually even double the rest of what you get with assisted in general with assisted conception when you go for day 2 and day 3. Interestingly, ICSI seems to increase the rate a little bit as well, which kind of shows that you shouldn't be doing ICSI when you don't need it. So really, from that point of view, I think what I would like to see as a clinician as the future direction is to try to develop methods to get, if you can, equivalent, if not better, estimates of quality at the cleavage stage in order to be able to allow a confident selection and a single embryo transfer at day 2 to 3 instead of having to rely to blastocysts. And the reason I stress it is because a lot of tests which are being developed, like a lot of trials of PGS, actually rely on blastocyst transfers, which means that it's pushing us more and more to have to grow embryos to that stage rather than actually trying to find tests that can actually do the opposite. So I hope that in a kind of very quick tour, I managed to dispel some of the myths that I believe exist in IVF. I've got another at least double of those, but not for today. And I know it's late and we've overrun, so I hope you enjoyed it.